you, Professor.
Yeah, thank you. I'm afraid we are going to have a lot of repetitions because, of course, when we talk about factors determining the durability of mitral valve repair, many things are due to the surgeons, but many things are also due to the pathology. So it's difficult sometimes to distinguish things. Certainly, this is the very first recommendation coming out from the new guidelines. Mitral valve repair should be the preferred technique when it is expected to be durable. So the durability certainly is a very, very important issue in mitral valve repair. We have to consider that, and whenever we do a mitral valve repair, we should be concerned about the long-term results of this procedure. This is the paper was alluded to before, and there is a paper by Professor Fleming from the University of Leuven, the Catholic University of Leuven. Is a paper which appeared on circulation about 10 years ago on recurrence of mitral valve regurgitation after mitral valve repair in degenerative valve disease. And is a very important paper. This paper has been criticized because the results were not optimal, they are suboptimal and so on, but actually this is really the very first paper coming out with echocardiographic results, careful echocardiographic follow-up. So I think it's a very, very important paper. And in this paper, so it was they found that freedom from reoperation at 7 years was pretty good, but if you look at the echocardiogram, you see that only 71% of the patients at 7 years were free from mitral regurgitation more than 2+. So this is a very important information, and certainly delivering a shadow on this type of surgery actually is a remarkable number of patients with residual mitral regurgitation. So talking about degenerative mitral regurgitation, certainly the type of lesion has an effect on later results. If we go back looking at the literature, we can see immediately that there's a big discrepancy historically in the outcome of patient who had a posterior leaflet repair versus patient who had an anterior leaflet repair or both leaflets. There are data from the initial experience of Carpentier in the early 70s. The follow-up is extremely long. It's a follow-up, the endpoint was a reoperation, but was up to 25 years, and you see the significant difference according to the location of the prolapse. And also other papers and studies are supporting this finding. Here is the paper from the Mayo Clinic, which was reported, which was published more than 10 years ago. And on the vertical axis, you see the reoperation rate, and which is remarkably different in patient who had a posterior leaflet prolapse and patient who had anterior leaflet prolapse. And reoperation rate at 10 years was basically double in patient who had anterior leaflet prolapse. And again, other reports in the literature are showing this difference in outcome in patients who had a posterior leaflet and anterior leaflet prolapse. These are data coming from the Cleveland Clinic. Overall results are extremely good, but you can see here there is a significant difference in reoperation, freedom from reoperation between patients who had a posterior leaflet and anterior leaflet prolapse. And again, I could continue presenting you a lot of papers showing this finding. Comparison of outcome, this is the Tyrone David experience. Again, good results. You see here with the posterior leaflet prolapse, 96% freedom from reoperation at 12 years. and much less, significantly less for patients who had anterior leaflet prolapse. Bileaflet prolapse is something in between. So really the worst, I don't understand exactly why. Maybe you have some idea on that and you can interpret those data from the literature, but certainly patients with the anterior leaflet prolapse are the worst in terms of outcome after mitral valve repair. And another important aspect which has been stressed in the literature is also the type of degenerative disease you are dealing with. Patients with the Barlow disease are reported to have an outcome which is inferior compared to patients with a fibroelastic deficiency. I don't know if this is your experience. What is your experience on this, Frank? What? Very similar, you know, and also in the Belgium experience, in the University of Leuven experience that has been reported, that the Barlow's disease are associated with worse result, probably also because of the complexity of the mechanism of regurgitation, probably because often calcification of the valve are there, and so on. But certainly this is something which has to be taken into account. But this I wanted to tell you that in recent experiences, so all the above factors, so the type of lesion, the location of the prolapse, and also the type of degenerative disease are not affecting durability of mitral valve repair anymore. And this is something, the new information that we have from recent experiences, at least in people who have experience in this type of surgery. You all agree with this, or you still have some? Yes, all these things practically seems to have disappeared. So now the durability, the freedom from reoperation. This is a rather old papers, but still very important, is the freedom from reoperation, is the Cleveland Clinic experience. This was an old paper, but 92% freedom from reoperation at 10 years. And look at the cause of failure. So about half of the patient had reoperation because of valve-related problems, and less patient had procedure-related failure. And this, you have seen this already many times today. I'm sorry to show you it once again, but this is what I had to show you. You see that patient who had procedure-related failure, which are actually a little bit less than the patient who had the valve-related failure, have an early failure, and they required operation earlier. Patients with valve-related problems require the operation later on during the follow-up. So let's look at the procedure-related. These are really the surgically related, let's say, factors affecting the repair. Suture dehiscence. You know, that's what you have to say. We have to tell that we have to be careful how to put the stitches. That's it. It's not much to say. Hemolysis. This is a nice consideration. I think we have to say we do not have to accept residual incompetence because this is a little bit what we have been discussing this morning. If we have residual incompetence, you never know what happens. Can have some evolution. The residual jet can be eccentric, can go against the ring, the prosthetic ring, and produce hemolysis, massive hemolysis, and these patients are required reoperation quite soon. So this is an important aspect. This is surgically related. We do not have to accept residual hemolysis, residual jet. So if it is possible, we have to correct, to identify the mechanisms, or otherwise, even the edge-to-edge, even the edge-to-edge could be accepted in a case like that, I think personally, but I don't know if the other people agree on that. But hemolysis is a potential complication of a residual jet. Chordal shortening is an operation which has been abandoned, so I think that this has been very well pointed out by Jean-Louis. Louis. And And you see here the difference between the chordal transfer and chordal shortening. There is a remarkable difference in outcome. So this is, has been potentially eliminated. There's nobody of us who is using chordal shortening at the moment. We have the artificial chord, we have transfer of the chord. There are other methods to deal with this type of thing. Systolic anterior motion, there's really nothing to add with that. Has been discussed extensively also this morning. We have really to be very aware of the fact that there are conditions favoring some, and of course we have to take precaution to avoid some. This is something that can avoid this complication, and this is nowadays rather rare. But still can occur. Is a question of experience, but is a question, I think, of identifying preoperatively patients who are prone to this type of complication. The other thing is incomplete initial repair. This, in our experience, quite often the incomplete repair is due to lack of annuloplasty. Now we don't do that anymore. All patients are treated with annuloplasty, but in the past, some of the patients, particularly those who had, for instance, endocarditis, acute endocarditis, or where the annulus also, other type of where the annulus was not particularly enlarged, then there was a tendency to avoid annuloplasty. This, we don't do that anymore. Incomplete initial repair can be also is consisting with the residual prolapse which has not been treated, with the clefts which are not closed. If you, for instance, you do some kind of folding plasty, leaving the cleft, then can be a combination of very bad combination. You can have residual mitral incompetence. Annuloplasty, as I told you before, is an important addition to every kind of mitral valve repair. Let me tell something about the valve-related complication, because this is something that, surgically speaking, we can prevent this complication. Nowadays, I was mentioning this this morning, using this the 3D echocardiography and using the cutting planes, we can actually detect not only dominant lesions producing insufficiency, but we can always also detect secondary prolapses with only 1-2 millimeter, and these are areas where potentially a prolapse can develop in the follow-up. So we learn after this consideration and knowing that the prolapse can be the major cause of valve-related failure, we thought that was important also to correct secondary lesion, even if they are not producing mitral insufficiency. Of course, you have to rely on a good echocardiographic study, but this is something that maybe can contribute to improve late results of mitral valve repair. This undersized annuloplasty for secondary mitral regurgitation, now we are going to functional or secondary mitral regurgitation. This is the type of operation which is most commonly done for this type of condition. The ring which is used should be a complete ring, should be rigid, and I don't think that there should be shape, but once you identify very well a central regurgitation or a lateral or a commissure regurgitation, maybe if you have a shape ring with a predetermined shape, just to force the coaptation exactly at the point of the regurgitant jet, that can help in having a better result. Just to force the coaptation where the jet is identified. So this can be a trick or an addition to your type of to your procedure in the context of functional mitral regurgitation. Certainly, annuloplasty is superior to mitral valve replacement. And this came out from a meta-analysis looking specifically at short-term and long-term survival. So, but certainly annuloplasty is associated with the recurrence of regurgitation. And I think it's very important to know exactly what are the predictors of recurrent secondary mitral regurgitation after undersized annuloplasty. This has been already very well presented before, but I think if we follow strictly and these rules, which are listed in the recent guidelines, we can avoid the carefully selecting the patient, we can avoid recurrence in the context of undersized annuloplasty. So we can really decide now in which patient we have to replace the valve and which patients are good candidate for mitral annuloplasty, undersized annuloplasty. If we do that, probably the recurrence is going to be much less. This is something that I would like to say about the rheumatic disease, but already that has been discussed previously. I want to show you that here in the last column, freedom from reoperation. These are a number of series where the repair rate was rather low, but even in selected patients, certainly freedom from reoperation was, you see the number of years of follow-up in the between parentheses, you see is the freedom for reoperation is rather low, generally speaking. So I doubt that we should push our repair technique very much in patients with rheumatic disease. Certainly, once you have a young patient with a predominant mitral insufficiency, no mixed lesion, no atrial fibrillation, I think probably these are the good candidates for mitral valve repair. And if we consider that, you see, we can have results with the repair which are superior to replacement. You see, this is a slide referring specifically to survival, but there are similar data regarding reoperation. So this is a little bit of things that I wanted to tell you. Thank you.